So we come to the last session that will be the future directions for the molecular diagnostic and the end of age by 2030. So I will have start with my presentation and then following by the opinion and point of view of the other speakers and also from their audience. So the vision of 2030 is a global commitment to end AIDS as a public health threat by the year 2030. This vision reflects a fundamental shift in HIV response from a model centered mainly on treatment to one that emphasizes precision prevention, early detection, and sustained viral suppression. Molecular diagnostics are a core enabler of this transformation, supporting every stage of HIV care continuum. So, molecular diagnostic provide highly sensitive and specific tools for HIV detection, monitoring, and prevention. They allow us not only for diagnose HIV accurately, but also to guide treatment decisions, detect drug resistance, and generate data for public health planning. In the context of Vision 2030, molecular diagnostics are no longer optional, they are foundational. Early detection is one of the most effective strategies to control HIV transmission. Molecular testing enables diagnosis during acute and asymptomatic infection, when individuals may not yet know their status but are highly infectious. Early diagnosis allows timely initiation of antiretroviral therapy, improving health outcomes and reducing onboard transmission. Viral load monitoring is the gold standard for evaluating treatment success. Molecular assay allow clinicians to confirm viral suppression, identify treatment failure early, and intervene before resistance develops. Sustained viral suppression is essential not only for individual care but also for achieving population-level prevention. Molecular diagnostic also play a critical role in detecting HIV drug resistance. Resistance testing supports optimized treatment selection and informs national treatment guidelines. At the same time, diagnostic enable test and treatment as prevention strategy, turning diagnostic into a powerful prevention tool. Recent innovations has expanded the impact of molecular diagnostic. Next generation sequencing enables comprehensive drug resistance surveillance and molecular epidemiology, helping map transmission networks. Digital PCR provides ultra-sensitive viral detection, supporting low-level viremia monitoring and HIV reservoir research. And as we learned from Dr. Nusala that this technique also used for TB gene expression analysis. Despite these advances, significant challenges remain. High costs, infrastructure requirements, access disparity, workforce limitations, and data governance issues continue to limit impact, particularly in high burden, low resource setting. The clinical gap is not technology, but implementation and equitable access. To close this gap, molecular diagnostic must be integrated into national HIV strategies and healthcare systems. Affordable and simplified testing platforms must be scaled, laboratory networks strengthened, and workforce capacity developed. Global collaboration between governments, researchers, and funders is essential. Achieving Vision 2030 requires innovation aligned with equity. Molecular diagnostic must translate from laboratory advances into real-world impact for all populations. With strategic investment, collaborations, and commitment to equity, ending AIDS as a public health threat by 2030 is an achievable goal. So thank you very much, and we will have vision from the other speakers. Maybe we start with Dr. Nusra first.
Okay, hello. Yep. So for me, I think now the molecular method is very high sensitivity and high specificity. So for HIV, the challenging is that with a lot of, for example, global donation is withdrawing their donations from the HIV community and the sports. I think that could be really challenging in terms of not just Thailand.
Yes.
Because we rely, for HIV, you don't rely on a lot with the external or foreign funds, but for TB, we still rely on a lot, especially in terms of a gene expert. That is once it's totally withdrawn, like how can Thailand can be subsidized all of those costs for molecular technology. And being in this field for a lot of years, it seems like the cost for Thailand is increasing every year. Yeah. So and then we didn't own any technology by ourselves, so that is very challenging. How we can funding these new tools or even implementing it in the future.
Thank you.
So can I just pick up on some of those questions? Yeah. So I think the cost issue is really, really important. And in general, the cost of these things should be coming down. We've had PCR technology for a long time now. It was new technology in the 1990s and well beyond that now. So the price of this should be coming down. I think while I agree that molecular tests are very important, there are some barriers when you centralize everything. And we've heard in a lot of presentations during the last 2 days about where the gaps are in diagnosis and treatment and the number of late diagnoses. I think there are, I think things like the gene expert, which, can be used as point-of-care tests. They can either be used centrally or they can be positioned within communities and community healthcare services. And so I think looking at disseminated models of that where these sorts of machines can be used for multiple, the diagnosis of multiple infections. So not an expert that's dedicated to TB or HIV or anything else. Because there are now not just the expert, but other closed point-of-care molecular platforms where you can, use different chips to diagnose TB, COVID, flu A, flu B, RSV, chlamydia, gonorrhea, et cetera, et cetera, et cetera. And so making really efficient use of those quite expensive resources and empowering the local healthcare workers to do that with centralised QA, QC, organised through the reference laboratories, I think is a model that we need to start exploring. And at least in, we've been doing this at the Kirby, we've been exploring these a lot in Australia in our isolated Indigenous communities, particularly around the diagnosis of sexually transmitted diseases, which are very high, occur at very high rates in those isolated communities. And to use a centralised facility, it usually takes about 2 weeks for that result to come back to the patient. And by that stage, the patient may have moved to another community. There are also barriers in those small communities to presenting repeatedly to the healthcare service because people start to realise that you're using the healthcare service and want to know why. So we've been testing the use of point-of-care tests, molecular tests, initially for STIs, but then for respiratory viruses in those settings. And we've shown that that's effective and that we can have a turnaround time of, essentially an hour rather than 2 weeks. And we're building sort of test and treat algorithms. But more importantly, and this is a bit confronting for people that work in labs all the time, but what we then did was we showed that it was economically cheaper to do it this way. So that it was we actually then got health economists to work on the model. And so I think, what we have to do is start looking at various models, testing those models, whether they work, but not just showing whether they work in terms of sensitivity and specificity, whether they work in terms of acceptability to the healthcare professionals, but then to go to government with a health economics case that shows that it's a cheaper way of doing things. And I think, given the gaps we've been seeing and the gaps that we're likely to see increase as resources get less, then looking at new models of disseminated, not just disseminated care, but disseminated diagnosis and then care, and having those two things linked. And so, I think one of the things we're exploring at the Kirby is having not just point-of-care testing, but linking those to treatment algorithms so that healthcare professionals get the result and they get told by an algorithm exactly what treatment the patient needs, so that you're not reliant on experts at a central facility, and then the central facility gets the responsibility for any confirmatory tests that need to be done, but also for overseeing that the quality control at those disseminated sites is correct, that the healthcare workers are properly trained, and that the quality of the test is assured, because that's the thing those people can't do because they're not trained in those facilities. So I think it's a complicated and different model, but I think and it at first, when you first look at it, you think that has to be more expensive, but I think it's worth exploring. And I think there has been this, one of the things that has always I've found confronting is when I've gone to resource poor areas and they have something like an expert machine, but they can only use it for TB because that's what the donor said, right? And that's just really inefficient use of resources. And so I think as the cost of the main, once you've got one of those machines, the main cost is the chips that go into them. And, I think we need to really be lobbying, and hopefully as there's more competition for these closed systems, the cost of these things will be driven down by that competition. In the same way that overall the cost of sequencing and PCR in general has come down. If there's actually competition within the market, then hopefully the cost of those diagnostic chips that go into these machines will become cheaper, and those models will become even more viable. So I think, I think a lot of the future of this, if we're really going to, is really taking the tests to the community and the testing and treating into the community, rather than expecting the community to come to central facilities, and then the central facilities really become the coordinator of those and the quality assurance people that ensures that those disseminated networks actually work efficiently and deliver a high quality result. So it sounds like pie in the sky, but I think that's things that we really need to be looking at. And, you know, although we're looking at the Kirby in our Indigenous communities in Australia, we're also doing this across in clinics in PNG and in clinics across the Pacific. So in places like Fiji, Vanuatu, and those sorts of places to see if the model is viable. And we're not just doing it for HIV, but we're doing it for human papillomavirus and other STIs as well.
Yeah.
So that, you know, I think, and so I think, you know, perhaps the role of laboratory people is going to change. There will always be a role for those big central laboratories, but they will also they will need to take on a greater role in terms of them being not looking after just their own QC and QA, but looking after the QA QC of these disseminated networks.
So provide the QA QC to the different setting.
Yeah, and I guess the other thing is if you have large networks, then you potentially have economies of scale in terms of purchasing these chips. It's not each clinic purchasing the chips. It's the central laboratory purchasing them, and hopefully, because it's a bulk purchase, those, you know, you can drive the cost down, and then there's distribution from that to the sites. And you use the economies of scale to drive down the cost even further.
With the introductions of long-acting HIV PrEP, I'm just wondering whether it will influence the ability of us using this HIV molecular diagnostic method in detecting early HIV infection, especially among PrEP users, for those who having breakthrough infection. I'm a bit concerned about that. So can you share your opinion on it? Thank you.
Start with me first. So I think exactly within the prevention strategy and with the we PrEP for prevention HIV. So we need exactly the more sensitive techniques or assay for HIV diagnosis for people who receive the PrEP. So it should be like ultra sensitive or sensitivity more than the current testing that we have right now. Tony.
So it's a really good question, and one that actually keeps me awake at night. So just to add to what Sassy's just said, you know, I think there's different scenarios, right? So I think if you're on injectable PrEP, then unless you become non-compliant and you're in the tail, well, if you're in the tail, you'll get a breakthrough infection and you'll probably have a resistant virus, right? So that will become detectable on our standard testing, right? Whether it's serological or whether it's molecular, it might be delayed, but it will become detectable, right? If, however, you, particularly on oral PrEP, you come off it, you get infected, and then you start oral PrEP again, and it suppresses the virus, and you do that while the infection is still in the sort of eclipse phase and taking off, then you may be serologically negative because, you know, if you suppress the virus again, then the evolution of the antibodies is either frozen in time or it's very much delayed and much weaker, right? And may take years to declare itself until you get breakthrough infection. And if that's the case, you're also suppressing the RNA, right? And you may be suppressing the RNA to very low levels. So I think the answer, and something that we've really like the field has fallen down on, you know, the tests for detecting HIV DNA were better 15 years ago than they are now, right? And so I think we need to really encourage the diagnostic houses to look again at HIV DNA as a diagnostic kit, right? Because if you have a really sensitive HIV DNA, even if you suppress the virus again, you should be able to pick up that DNA, right? And at the moment we use HIV DNA for neonatal diagnosis, right? But I think with more and more use of PrEP, I suspect that we'll need to rely on HIV DNA more, perhaps, right? And more, like one of the only accredited HIV DNA tests now is the Expert, right? Which is a good test, but it has a relatively high cutoff, right? So it's relatively insensitive in terms of the number of copies it can detect. So once it detects, it's a good test in terms of its specificity and sensitivity, but only if there's enough DNA to come in above the cutoff, right? And its cutoff is actually much higher than the old Roche DNA tests from 10 years ago. So it's sort of ironic that we've actually gone backwards in some ways.
Hi, my name is Andrew from Malaysia. I manage essentially what is a primary care clinic. And I think maybe I'd just like to seek some advice, because in 2025, I essentially realized that your comment on the economics of the situation is starting to be very real. Even as a standalone clinic, we would find it more expensive to send, a viral load to a lab compared to a quotation from the gene expert, company, for example. So I think this year we really want to attempt to scale up some sort of mini POCT lab if we can. And we very immediately came across some important questions. How do we store information? Who's going to do the tests? What are the workflows like? Because the primary care guys are not lab people,
Absolutely not.
Yeah, and we're slowly figuring out the space, the workflows, the resources. Would you have any advice to someone, coming from this kind of background and trying to go up? We're unlikely to get the situation where there's a bigger lab overseeing us. We're likely to go into this ourselves. Right, yeah.
So, I think there's a number of really important components. One is how you sort it out as a workflow issue and who's responsible, and then making sure those people are trained, right, and understand what the limitations of the test are, right, and understand. A lot of the tests have inbuilt quality control, so they flag if there's a problem, right? But it's not foolproof. So training on the tests is really important. Training to ensure that you don't get contamination, because with any of these amplification, again, there are inbuilt things in these tests to prevent contamination, but you get it, right? So, the companies might tell you that it's not going to happen. It does happen, right? And we've seen this. This is one of the issues we've addressed, right? We've had to address in the use of the test in the isolated Aboriginal communities. We've had problems with contamination, giving false positive tests. So it is really important that people who are conducting the tests understand what they're doing and understand the limitations of that, right? And understand the precautions they have to take to protect themselves, but also to protect the next specimen from contamination. And so I think it is the model we've pursued throughout this is to link these community health centres with experts. And I don't mean experts, the machine, I mean experts, the people. So that if there's an issue, and there's constant dialogue between those two, so that if there's any doubt about the result, if there's any question they have, there's sort of like a 24-hour hotline where they can get advice, right? And also we can then provide oversight to ensure that there's, that the quality is maintained, right? Because even though these are closed systems, they're not bulletproof, right? So I like your ambition, but I do think, I guess I come from running a big lab myself, right? And so I guess, and having been trained as a pathologist, I understand, I hope I understand about quality control and quality assurance, right? And so that's sort of central to delivery of quality results, right? And so I think perhaps exploring or even saying to Safid, if that's who you're going with, what support could they give you to quality assure, or are there people they know that they could link you with, right, that could provide that service? And also there's lots of people at the Kirby you could talk to about, because we've come up with different solutions for different scenarios, right?
I just add quick input into that. Apart from the prevention of the, contamination, yeah. And the other thing is that these kind of new POCT machines, we need to make sure, and I believe Malaysia has a very high standard in terms of medical devices. But again, even though does it pass CIVD or international standards, ISO 13485, I think. And the other thing is that make sure that not only just running the machine, but the QA and QC is the key. Because all of the laboratory here and everywhere else in the world, we control our standards in terms of service. We question it using the QC, everyday run, and the QA, comparing ourselves with other labs. So we are ensuring that our standard inside is okay, is at the acceptable standard. And the other thing is that we are not delivering a result that is totally different from other labs. So this is how a laboratory maintain their standards.
So I think the other thing you need to explore, and I don't understand the regulatory framework in Malaysia at all, so I could be completely wrong, but certainly in Australia, if you're going to report out a result and get a rebate or get paid for it, it has to be overseen by a pathologist. So, again, in the way we do this, we always have a qualified pathologist involved in some way in ensuring that, because again, it's really having that oversight to ensure the quality of the result, right? And also someone that takes responsibility for that result. And in most models, the buck stops with the pathologist, right?
Any more questions?
And again, in terms of economy of scale, if you've got a pathologist overseeing multiple sites, then it becomes much cheaper than you hiring a pathologist for your site, to work whatever it is, 6 hours a week or something, right? Mm-hmm. I don't know what it would be in terms of hours per week, but even if it's a fractional appointment, it's still an outlay for the clinic, right?
If no one else has a question, maybe just a quick one about what you mentioned about detection limits, right? So obviously in this process, we are pitting Safid against Abbott and looking at all their tests and how we're going backward, ironically, with detection limits with VL. Would you have any comments on that? I mean, Abbott would try and convince us that that's fine, there's no practical difference why we need anything lower. And, would you have any comments on that?
I think the main issue is really around, in terms of detection limits, is really around, for me, and I don't even know if it's something I should be losing sleep about, is really around the diagnostics rather than the monitoring, right? So missing positives because you're your cutoff is too high and you've resuppressed the virus with the PrEP, right? Which is no longer PrEP but is two-drug treatment, right?
Yeah. Yeah. This.
I'm Rapi from IHI, the Institution of HIV and Innovation. I have a question. Beside the gene expert system, could you please suggest or recommend us what other molecular POC platforms that are available or also the reliable that we can use beside the gene expert? Thank you.
So, look, I don't have all the trade names at the front of my head. I used to, but I don't anymore. And I haven't really kept up with, the sort of competition in the field, I have to say. But, certainly Abbott is one provider of that. And, I have to say that the Abbott viral load test on the Impema machine is fantastic for neonatal and child diagnosis because it uses very, very small volumes of blood, much smaller than you need for the expert, and works really. We've been running that in a neonatal clinic in Moresby in PNG, and it's run really, and the nurses run that for us, and it's run really, really well. It's been, but I think Pasteur Merieux and Biomerieux and others are, there's a lot of, and perhaps not in HIV, but in other infectious diseases, there's a lot of stuff coming through. There's companies like SpeedX in Australia who are developing alternative approaches as well. So I think there's a lot of movement in this space. I don't know if you know her, but the person that I know that's across this and keeps a finger on the pulse is Tanya Applegate, who works very closely with Rebecca Guy, who works very closely with Nitya. So there would be a link there. Tanya is very much across what's happening in the field and would be a good point of contact. And she's not paid by any of those companies.
Okay, and the back.
Yes, it's not a question to you, but just to introduce because of you mentioned about gene expert. I'm actually representative for the gene expert in Thailand. So we just set up. By the way, my name is Dr. Soming. Based here for just joined the gene expert for 1 year. So yes, we are more than happy to share more information. And actually Thailand, the good news is recently the HIV qualitative, we have completely registered. So then you can test the HIV qualitative with the dry blood spot here. And also viral load, I think is quite common. Many hospitals here in Thailand already been used. Yes, so yeah, we can connect later if you'd like to know more about our products, but thanks for mentioning it.
Yeah.
Yes.
Yeah, before, so any questions? So I tell more you information. So tomorrow we will have session, the last session for about the point of care testing. So you can have more information on the tomorrow session. Yeah. Okay. So if we don't have any more questions, so we have very productive discussion. And I think the be time to end the session. So thank you very much for our great speakers and all the audience. Thank you every comments or input that you have. So we finish this session, and thank you very much for your attending the lab workshop, and see you again next year. Yes. Thank you.